Welcome back. I'm Mabel Jong, and you're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. And a special welcome to those who are joining us online via our live stream. Dr. Charles Sorenson is in the studio. He is President Emeritus and CEO of Intermountain Healthcare, and we're so pleased to have him back with us today. Dr. Sorenson, it's so great to see you.
Thank you. It's a privilege to be able to visit with you, and I'm enjoying the Congress, learning lots of new things.
Terrific, terrific. Well, we've had a lot of things happen here in D.C., just really over the weekend. We are hearing that we should have a decision or some type of vote on the Affordable Health Care Act, which I guess a lot of people are watching very closely. But you also think that perhaps government should get out of the way of healthcare stakeholders and let them figure it out. Is that right, or?
Well, to some extent, I'll tell you, I think that government plays an absolutely essential role. They're the biggest healthcare purchaser in the country, and through their regulatory powers, have a tremendous influence on us in healthcare. So we really need the federal government as well as our state governments to be working with us to find better ways to finance healthcare, to provide incentives for wellness, not just for fixing health problems, and to have regulations that prevent fraud and abuse but don't inhibit us from working together with physicians and as health systems and payers to do the right thing for our patients. That said, I think that the main work for transforming healthcare really has to come from us in health systems and large payers. We need to come together and fix these things on our own, not sit back and wait for the federal government or state governments to fix it for us. It just won't happen. Mm-hmm. I think we have the responsibility to make most of those changes ourselves. What
can be learned from what your leadership from what your time at the helm and now new leadership at Intermountain, what can we learn from what you've done over in your organization?
I think some of the lessons from Intermountain are, number one, if you have good outcome measurement systems measuring clinical outcomes and cost outcomes, and if you have the courage to really track those, our experience at Intermountain over the past 30 years is when you measure how you're doing, you're never as good as you thought you were. It's a sobering experience, and as Jim Collins says in Good to Great, you have to confront the brutal facts, mm-hmm. but then you also have to have a system for improvement, and we started implementing that at Intermountain 20 years ago now with system-wide clinical service line improvement projects that have really adopted evidence-based best clinical practice. And what we found in every single area in which we've done that is that the consistent use of evidence-based best practices established by medical and surgical specialty societies, result in better clinical outcomes for our patients and lower overall costs for the community. So that's counterintuitive to most people. Most people think, well, if you want to have better health care, you have to spend more. We already spend 50+% more than other countries, and we get worse healthcare outcomes in the United States than most Western countries. So mm-hmm. This is really an important finding. I think that's probably the most important thing. And finally, I'd just say is that we're fortunate in the United States that our clinical experts, our physicians, our nurses, the other clinical people, they're highly motivated to do the right thing for patients. And what we lacked for so many years was any objective measurement of how we're doing. But now that we have better ways to measure, it's highly invigorating for a clinical team to be able to say, hey, wow, we've made these changes. Now the outcomes for our patients are as good here as they are any place in the world. And it's a virtuous cycle that's self-reinforcing, that once they have that in one area, they say, how can we improve in some other areas?
Well, there's absolutely seems like there's an effort to break the status quo. People are trying to think outside the box, but we also have a cloud of this fee-for-service model that people were trying to make work for a long time. Is that going to continue to be available, or can it be abandoned at some point when people discover through their data that it really isn't the best method?
Yeah, great question. What's the role of fee-for-service versus what we might call population health management? I personally think that the fee-for-service model is the single greatest inhibitor to get us to where we really want. And I think the question we really ought to ask is, what do people want from our health systems in the United States? Do they really want the very best surgical outcomes and all of the best cancer treatment outcomes and all that? Yeah, if you have a surgically treated illness, that's what you want, or if you have cancer, you want. But what we really want for ourselves and for the people we love is to not need those in the first place. We want to be able to live the healthiest lives possible. And so we actually changed our mission statement at Intermountain Healthcare 3 years ago from excellence in the provision of healthcare services to helping people live the healthiest lives possible, to get upstream and to prevent illness and injuries whenever we can, to optimally manage chronic illness so that it doesn't lead to the healthcare disasters of renal failure, of heart disease requiring surgery and stroke and all that. And the fee-for-service system does not provide incentives for health systems to do that. In fact, we're penalized under the fee-for-service payment plan when we prevent somebody from having a stroke, or when we prevent a little baby from having to go to the newborn intensive care unit, when we effectively manage mental illness so someone doesn't need to be hospitalized. On fee-for-service, we get paid less for all those things.
Right.
Under population health, when we're responsible for the cost for a population, we can use the monies we receive as a health system, apply them to preventing those kind of preventable things. I think that's our future.
Right. And do you think the consumer is smart enough or has been equipped with enough information to question whether something is good or bad?
No, we need to do such a much better job of helping to inform consumers or patients before they become a patient or after they are. And the good news on that is we found at Intermountain, Mabel, that when patients are well informed on decisions, whether it's healthy life decisions or whether it's treatment decisions, when we give them objective information on what outcomes will be if they go on one treatment path versus another, we find that they make really wise decisions. In fact, our findings in a number of areas are that when patients are adequately informed with shared decision making, they make the same kinds of treatment decisions that physicians themselves make when they're the patient. And that suggests to me that we're making the right decision. And they tend to be less aggressive sorts of therapeutic decisions. They're more focused on quality of life decisions. I think those are the kind of things we need to do. And give people the tools to better manage chronic illness, which is huge.
You seem busier than ever.
No.
Even though you are President Emeritus now, you're still highly involved with Intermountain. And in fact, the idea of starting the Intermountain Healthcare Institute was your idea. What is that exactly, and why did you feel it was important to really not keep secrets, to yourselves, but really share the wealth of knowledge that you've obtained?
Well, thanks for asking about that. So it was probably about 7 or 8 years ago that I just, in talking to my friends who are CEOs of other wonderful health systems, the question kept rising, who's going to be there to lead these health systems in this increasingly complex intersection between administrative and clinical leadership? And specifically, who are the clinical leaders who understand that can lead health systems? Because one of my theses is that we really need to spend our time as health system leaders reinventing the way we give care, not just get bigger and get scale and all that. I mean, to some extent, scale is important for efficiency, but really we need to reinvent care. And so you need to have people who really have a very deep understanding of what healthcare processes are for the caregiver and for the patients. And those are clinical folks. But they don't usually have a lot of exposure to the kind of leadership decisions. So we thought about forming a leadership institute that would bring together capable, high potential, mid-career clinical leaders and administrative leaders, help them learn together from one another and from case studies and simulation learning, and offer that to people around the country where we can bring good people and learn together these important decision-making things in healthcare. Because I think healthcare decision-making has to be different than any other business. Yeah, we have to be sure that it's financially sustainable for the future. But when it comes down to it, this is about people's lives and their health, the very most valuable things to any of us. So healthcare decision-making has to be different. So that was kind of the genesis of my thinking. We needed a healthcare leadership institute at Intermountain, and the board knew that I wanted to step down from the CEO role at age 65 and a half, and so did that, but they asked me if I'd stay on and be the founding director of our Intermountain Healthcare Leadership Institute. And I'm really honored to do that. I'm looking forward to developing that course and learning along with all the rest of our team how to do it better.
Well, it sounds like we're all lucky that you're doing that. Thank you, Dr. Sorenson.
My pleasure.
Well, it is very pleasant to have you back here again. What does keep you coming back to the World Health Care Congress year after year?
Well, as I said at the very first, I mean, the reason I like to come, I mean, it's nice that I'm invited to share some perspectives that we've learned at Intermountain, but mostly I come because it's an opportunity to learn from other people. One of the things about the World Healthcare Congress is you have so many different tracks that I can get exposure to people on the front line of a whole bunch of different aspects of healthcare than I otherwise would. And it's that learning experience that helps me bring back new ideas to Intermountain Healthcare to stay current, but also sometimes just to say, yeah, our direction, our strategy is the right one. It still is making sense in this rapidly evolving world.
Terrific. Thank you, Dr. Sorenson. A pleasure.
Thank you, Nina.
And I'm Mabel Jong. Thank you for watching. Stay tuned.